And this is a part 2 to Vasculitis 101 with Dr. Kenneth Warrington. We're asking some more questions that we just couldn't get to in the first part of the webinar. And so if it's okay with you, Dr. Warrington, I'll just dive right in.
Sounds good.
So we got some questions back from some patients that are very interesting. The first one is there more focus and research on finding a cure for vasculitis or for developing better medications to manage the disease? And what would a cure for vasculitis look like?
Yes, it really is an excellent question. And of course, we, just like our patients, would love to have a cure for vasculitis. I think in medicine, when we talk about a cure, we're referring to a condition where we could treat for a certain amount of time, and then we would stop the medication and, the disease is over. So for example, just like we treat an infection, if somebody has a bronchitis, we may give an antibiotic for 5 days. You stop the antibiotic, and we consider the disease cured. It's not a chronic condition. Unfortunately, with vasculitis, with any autoimmune disease, we tend to focus more on disease management because we don't yet have a cure. So a cure would look like, in the ideal world, we would have a medication. We would give the medication for a number of days or weeks. And then when we stop the medication, the patient would be cured, meaning that the disease is gone and doesn't come back. Of course, with vasculitis, it's different. With vasculitis, we manage the condition. And so we oftentimes will keep patients on medications for months and years because the medications work best when the individual is on those medicines. The medicines are able to keep the disease in check and control. But on the other hand, as you all know, as we reduce or stop the medications, the vasculitis can come back. That tells us it's more of a chronic condition, and we've not successfully gotten rid of it completely. The autoimmune process stays there, and of course, there is a focus, I think, on definitely it would be wonderful to have a cure for vasculitis. We're not there yet. The reason I say that is because, of course, vasculitis is one of a large group of autoimmune conditions, and we really don't have a cure for any of the autoimmune conditions. I think later on there's another question about kind of learning from other autoimmune diseases. But certainly the current research agenda is to find medications to better manage the disease. One of the things that we see in vasculitis is, of course, still a lot of use of prednisone. And we all know that prednisone has a long list of side effects that can be difficult to manage and add to a lot of the discomfort from the disease. Again, not so much the disease itself, but the prednisone oftentimes has a long list of side effects. And so we want better medications that allow us to use less prednisone. I think that's a lot of the focus. Of course, we want medications that keep the vasculitis in remission for as long as possible. Yes, there are efforts in place to find better medications. Of course, at the same time, there are efforts to find better blood markers, because for some forms of vasculitis, we still don't have a good blood marker. So we have ANCA testing for GPA and MPA, for example, but say in giant cell arteritis, in Takayasu, in PAN, we don't have a reliable diagnostic blood test. And so in conjunction with research on looking for better blood markers, more importantly, research looking to understand the cause of vasculitis, the triggers of vasculitis. And I think better understanding of that, of course, eventually will guide us along the path to finding that cure. And we look forward to the day when we have that.
Well, I can tell you as a patient, we all look forward to that possibility.
Absolutely.
And another question from another patient, I hear a lot about how patients should be involved or partner with their doctor managing their vasculitis. In what ways can a patient take ownership and be actively involved in managing their illness?
Yes, it is really wonderful to see patients who are motivated to be involved in their care. I appreciate that as a provider, and I think it's very important for patients to be involved in their care. So how could they be involved specifically? One is being educated about the disease, and I very much enjoy referring my vasculitis patients to the Vasculitis Foundation website so that they can learn more about the condition, they can understand what symptoms to expect from the vasculitis. Of course, they may already have experienced some of those symptoms, but sometimes there may be other symptoms that can come along down the road. So knowing which symptoms to watch for that may indicate a relapse, knowing which symptoms to watch for that may indicate a side effect of their medications, knowing when to call the provider. Another important aspect is to take ownership with, for example, blood monitoring. A lot of the medications that we use require periodic blood testing, sometimes every 2 months or every 3 months, or even, for example, in patients with giant cell arteritis, sometimes I will have my patients check inflammation markers monthly. Perhaps in patients with GPA, we may be asking for kidney function tests, liver tests, urine samples, and so forth. And I think the patient is really the best empowered individual to keep track of that, because we do have reminders in our system, but of course we're trying to keep up with a large volume of patients, and everybody's human, and sometimes there could be a misunderstanding or a lab that's missed. And so having patients be involved in, when should I have my blood draw done? When is my next appointment? Sending reminders to providers about all of that. So I feel reassured when I see a patient who is very engaged and involved, because I feel like we're partners. And then if I, am delayed by something or I'm not perhaps on top of the exact schedule, then I know that the patient is careful about watching their schedule and sending reminders and periodic questions.
Well, that sounds like we could all be better partners. We actually had a webinar recently with the Vasculitis Foundation has a journal that vasculitis patients can use, and that sounds like a great
Perfect.
A tool that maybe they could also use.
Absolutely.
From another patient, the question comes in, it's sort of what we were talking about before. Could research into other autoimmune diseases like lupus help to find a cure or better understanding of vasculitis? And is there some commonality with other autoimmune diseases?
Yes. Oh, absolutely. We learn from other diseases, and we learn both in terms of how changes in the immune system lead to development of autoimmune disease, because changes in the immune system that may happen in one disease may be similar to immune changes that happen in other diseases. And then we also borrow medications, because we see, for example, you take prednisone, of course, that is used in many autoimmune diseases. You take a discovery, for example, a medication like methotrexate, used in rheumatoid arthritis, but of course also known to be effective in vasculitis. You take a medication like rituximab, where that was first developed for blood disorders, and then it's seen to be effective, and of course became an important treatment for patients with vasculitis. We borrow from rheumatoid arthritis, for example, Actemra, studied in rheumatoid arthritis and then studied in giant cell arteritis. And in some ways that helps us, because of course vasculitis, most forms of vasculitis are very rare conditions, whereas other conditions like rheumatoid arthritis are more common. So sometimes it is faster to develop treatments for things like rheumatoid arthritis because they're more common. Sometimes there also is more of a financial incentive to develop drugs for more common diseases, but then we have a lot to learn from that. We can apply them to vasculitis, study them in vasculitis, and figuring out what works in vasculitis. So yes, there is a lot of commonality with other autoimmune diseases, keeping in mind that these are all conditions where the immune system is really the culprit, right? So it's the immune system that in vasculitis attacks the blood vessels, In lupus, it may be attacking the kidneys or the joints. In rheumatoid, it's attacking the joints. So there's something about all these autoimmune diseases which really the common theme is it relates to something that goes wrong in the immune system that stops it, that starts the immune system to attack parts of the body that, of course, it shouldn't be doing. So, yes, very good question. A lot of common themes in autoimmune diseases, and we share research. We share treatments, but of course, one treatment that works for one autoimmune disease doesn't always work in other autoimmune diseases, which is why then there are clinical trials in vasculitis and in different forms of vasculitis to specifically then test those treatments in each of those conditions.
But it is interesting that some of the same medications found to be good for different autoimmune disorders. But interesting to know. Another patient says, I'm currently into my 6th month of being in remission, and I want to stay here as long as possible. Is there research into how to prolong a remission phase or to make a flare a shorter time?
Yes, of course. We want our patients to stay in remission for as long as possible.
Yes.
Also, one of the reasons we want that, of course, we want that because we want patients to feel well. We also want to prolong remission because as long as the patient is in remission, we often are able to taper or even stop glucocorticoids, right? Whereas if patients have more frequent relapses, then we're often going to use more prednisone, which again brings us into those prednisone-related side effects and the damage that prednisone can cause. So being in prolonged remission helps us use less prednisone. That's a very important point. And then how can we prolong the remission phase? We can prolong the remission phase with having better medicines, kind of similar to the first question, with having better medicines that control the vasculitis, that keep the vasculitis in remission. So for example, in GPA, we know that rituximab and periodic infusions of rituximab can keep patients in remission, and there have been trials to show that it works better than some of the older medications like azathioprine or brand name is Imuran. And so part of the research is really understanding how to keep patients in remission and finding those best possible medications to keep the patient in remission. Now, I do get a lot of questions, what is the cause or what triggers a relapse? And that's something that we still don't know yet. It would be wonderful to know, what triggers those relapses. We're not there yet. A lot of research going into trying to understand why some patients relapse and others don't. There are some blood markers. For example, sometimes we can follow the ANCA test in people with GPA, although it's not perfect. We get a lot of questions about, is there something I can eat? Is there something I can do exercise related? Are there supplements that can help, prevent relapses? Those are common questions, and we're not there yet. We don't really have something as convenient or as easy as that. We all, of course, want to eat a healthy diet, stay active, exercise regularly, but it's not been shown that those are able to prevent relapse. We get questions about stress. Is stress going to cause a relapse? And we know that stress is not good for our health. We know that stress is not good for the immune system. So we definitely want to minimize that. But again, I think there is a lot that we still don't understand as far as what triggers those relapses.
Well, the big question. One day we hope it'll be answered.
Yeah.
And coming from another patient, Dr. Warrington, I'm due to have my rituximab infusion this week, but I'm concerned about it because of the COVID crisis. What are you telling your patients who have this concern or questions about the risk?
Yes, well, the COVID-19 pandemic has certainly changed our lives, has introduced a whole new condition and a whole new set of issues that we're all dealing with and that we're learning to deal with. This being a new disease, there are still way more questions than there are answers, of course. We are learning as we go along, and over the last few weeks, months, we've learned more. We know that this virus can cause a wide spectrum of illness where some people have few to no symptoms, but unfortunately there are those who develop more serious complications, especially when the virus is in the lungs and causes a pneumonia. And then there are some individuals who develop a very serious form of the illness. And of course, we know that when we treat patients with vasculitis, we are suppressing their immune system with medications that we are using, whether that is prednisone, whether it's methotrexate, rituximab, cyclophosphamide, and so forth. So yes, we do have concerns about the use of immune suppressants because we know that when we use immunosuppressants, we're not allowing the immune system to fight off infections as effectively as it would otherwise. So what to do with a rituximab infusion? There's no easy answer, and we have been basically taking the situation on a case-by-case basis. We have to very carefully balance the risk of the vasculitis with the risk of COVID-19. So it depends a lot on the circumstance. Of course, the first thing is, we want to, as much as possible, have patients avoid getting COVID. And so following the CDC recommendations of social distancing, masking, hand hygiene, and so forth is important. Whether it's worth delaying the rituximab or not is a complex question. There are individuals where I think that's a possibility, especially if the disease has been in remission for a number of months or perhaps years, if there has not been a severe relapse in recent months or years. So it's working very closely with your rheumatologist, your vasculitis provider, to understand how do I weigh the risk of the vasculitis flaring? Because of course, if we delay the rituximab, is there a potential that the vasculitis could flare? If the rheumatologist feels that the risk of flare is low, then delaying the rituximab would be reasonable to avoid suppressing the immune system further in the context of COVID-19. I hope that answers the question. It really is a complex situation, but I think working one-on-one with a vasculitis provider to discuss what are the risks and benefits in that particular scenario.
I think that helps a lot. I think that's from what I've heard from other patients, that's kind of one of the most common questions. And
Mhm.
so I think that gives them something to work with. And now for the next question. As a patient with vasculitis, should I continue to do social distancing, wearing a mask, staying at home, even if my state loosens the guidelines we've been following for the past few months?
Yes. I will start with saying, of course, as a patient with vasculitis, I presume that this individual is on treatment for vasculitis, right? So if folks had vasculitis in the past, the vasculitis is in remission, and they are among the fortunate individuals who are no longer on treatment, then of course their risk of COVID is the same as in the general population. But presuming that most patients with vasculitis are on some form of immune suppressant, then that increases their risk of having more serious illness if they were to contract the coronavirus. And therefore, yes, a patient with vasculitis who is on immune suppressants should continue to be very cautious and minimizing the risk of contracting the virus by continuing to follow those measures, the social distancing, wearing a mask, staying at home, minimizing contact with groups of people to minimize the risk of contracting this virus, because with suppressed immune system, the concern, of course, would be that it may lead to more serious complications. Absolutely.
Hmm. Okay, and we keep hearing about possible treatments for COVID, but I can't keep them all straight. Could you comment on some of the current studies and research for therapeutics and development of vaccines, possibly? And which ones do you find most promising?
Wow, yeah, this is a rapidly evolving field, and of course, you could be glued to the TV and to the social media because the news is coming at us at a very fast pace, and there is a lot of stuff out there now. On the good, so first of all, I totally identify with this individual because I have a hard time keeping them all straight as well, because there is so much information. But that's also a good thing, right? Is because we are really seeing kind of a remarkable response from researchers, from academic medical centers around the world to accelerate, to really speed up and advance the research going on to understand the virus, but then also to understand which treatments may be effective. And we actually had our medical grand rounds today here at Mayo Clinic was all devoted to the clinical research, the clinical trials related to COVID-19. And I very quickly before this webinar searched the clinicaltrials.gov website. This is a website that tracks all the current research going on COVID. And when you search COVID, there were over 1,000 studies going on currently that are registered on the clinicaltrials.gov website for COVID-19. And of that, 639 were interventional trials, meaning there are 639 trials worldwide going on with some form of treatment aimed at trying to help patients who are infected with the virus, or even to help individuals who have been exposed. So I totally agree. It's hard to keep them straight because there are literally hundreds and hundreds of studies going on. And what is being studied? So there are medications that are directly what we call antivirals. So medications that work directly on stopping the virus from replicating. And these are medicines that are borrowed from other conditions, for example, like treating hepatitis C, which is also a virus, medications, for example, that may have been used to treat HIV. So there are medications that work on the virus itself. There are medications that work on the immune system. So in some patients with COVID-19, especially in later phases of the illness, the immune system has an exaggerated response. There's this very serious but kind of unchecked immune system activation. We'll call it cytokine storm. In those individuals who are very sick, oftentimes in the intensive care unit, there are medications, some of which are familiar to the rheumatology patients, like tocilizumab or sarilumab. These block some immune system messengers like IL-6. So there are medications that work on the immune system that are being studied. There are medications, I'm sure a lot of folks are familiar with the medication hydroxychloroquine that is used for lupus and for rheumatoid arthritis, and that is being studied for COVID. There are a number of other medications. Steroids are being looked at. There's an interesting treatment called convalescent plasma. That's where the blood is taken from people who have recovered from COVID and then is transfused to individuals who are infected. So again, lots and lots of studies, but I will point out that as of today, there really is no medication that's approved for the treatment of COVID-19. All of these things that I mentioned are best given as part of a research-based study so that we can learn from them and we can understand which ones work and which ones do not. In the news today, you will see a lot of information about a antiviral medication called remdesivir. It's a medication that works directly on the virus. There are some initial promising results, but again, I think we need more information. So we are all eagerly kind of glued to the news and to the medical literature to see what's coming down the pipeline. We don't want to jump into things prematurely. but we want to let these clinical trials show us results, because of course every medication has its good potential benefit, but also its potential side effects. So we have to be very cautious when we are thinking about using these medications. They are best used in the context of a clinical trial, so we can learn from them. And I am anxious and excited to see what develops over the next few weeks and months. With regards to the development of vaccine, another huge area that's ongoing. I read an article this morning. There are over 90 vaccines that are being trialed for this coronavirus all over the world. So that's very encouraging, because it tells us that there are researchers looking at this all over the world, and these vaccines would help to prevent people from getting sick with this virus. But of course, it will take very likely many months for figuring out, which one or more of those 90 vaccines, first of all, are they effective? The other most important thing is, are they safe? And eventually, if one is identified that is safe and effective, then it has to be scaled up into massive, massive quantities to protect as many people as possible. So this is a rapidly evolving field. The reassuring thing is that there are many, many academic medical centers. There are many very smart researchers that are working on this. I'm confident that we will have effective treatments and we will have effective vaccines, but it's going to be difficult for us to be patiently awaiting for that day.
Well, we will all try very hard to wait for all of you wonderful health professionals that are out there working to make that better for us. And so, Dr. Warrington, one last question. We've heard so much about telemedicine right now, and I know you said that you're actively doing it. You're in your office and you just had one session right before us. And so could you tell us the pros, cons, difficulties, positivities of telemedicine right now?
Yes, it certainly has changed very quickly. We had just started, actually, even before COVID, at Mayo, to explore telemedicine, and I got trained on how to do video visits just a couple of weeks before this whole pandemic exploded. So we were kind of on the cusp of getting there, and then we really kind of got launched into learning this in a very, very short amount of time. But I do see substantial benefit. Of course, the reason we accelerated this in the COVID pandemic is to keep both patients and staff safe, so that we can keep social distancing and have patients not need to travel and be in lines and be in large medical centers. So that's kind of the reason we developed it, of course. But I do see a lot of benefit, because it allows us to stay in contact with the patient. Now, one could say, yes, you could use phone as well, and we've done that. It really is nice to be able to connect to that individual visually. In rheumatology, there are some instances where we may be able to see certain things. If there are things like a rash or perhaps some swelling in joints, for example, in the hands, that we can visualize on video, that is a plus. I think it allows us to connect with the patient. It allows us to get a detailed history and ask all the questions that we usually do in a context of a care visit. The downside, of course, is we can't actually touch the patient and examine, so there is a little bit of a limitation. But we can certainly provide advice regarding potential testing that may need to be done. Some patients even can have that testing done closer to home, perhaps even send us the results and then do a follow-up visit. We can give advice about treatment options. So there is a lot of benefit to it, really, without the patient having to leave their home, travel, stay in a hotel, incur even the expenses of travel. And so there are a lot of advantages. There are some downsides, but I think we will see more telemedicine be part of medical care in the future. There are also some legal and logistic issues where when we're providing advice across states, then there are some logistic issues in terms of licensure across states. Those have been relaxed in the context of the pandemic, but there'll be some more work to be done with that aspect.
Hmm, very interesting. I just want to say on behalf of the Vasculitis Foundation that we appreciate you taking your time to answer the questions today, because we know that you're out there on the front line working hard, and we do very thoroughly appreciate that.
Well, you're very welcome. It's my pleasure to talk with you and discuss these topics.